Hello, and I welcome you all to today's therapeutic forum of Sri Lanka College of Internal Medicine. This is our June lecture, and it will be delivered by Professor Saman Gunatilake. First of all, I thank you, dear sir, for accepting our invitation without any hesitation. And first, I would like to invite Dr. Kumuduri Jayasinghe, President of Sri Lanka College of Internal Medicine, to address the gathering.
Good evening, everyone. I warmly welcome all of you to another session of Therapeutic Forum organized by Sri Lanka College of Internal Medicine. This Therapeutic Forum was introduced this year to improve knowledge on commonly used therapeutic among doctors. And I greatly appreciate the speaker today, Prof Saman Gunatilake, for accepting our invitation and discussing a common and an important disease, epilepsy. I'm sure, sir, this will definitely clear many doubts that we do have with regards to management of epilepsy. I would like to thank Dr. Rangunasekara, one of our active council members, for organizing and moderating the event today. I invite all my colleagues, postgraduate doctors and all other doctors to witness a great lecture. And please do join with the discussion afterwards. Thank you very much.
Thank you very much, Dr. Kumuduri, madam. I think Professor Saman Gunatilake needs no introduction to our fraternity, but yet I will give you an essence of his prestigious career. Professor Saman Gunatilake, MD, FRCP London, FRCP Edinburgh, Honorary FRACP, FCCP. He's a consultant neurologist and Emeritus Professor of Medicine, University of Sri Lanka. He was appointed the first neurologist to the southern Sri Lanka and established the neurological unit in Galle. In 1994, he joined the University of Kelaniya and Colombo North Teaching Hospital as a senior lecturer and promoted associate professor in 1997. In 2007, he was appointed professor of medicine at the University of Sri Lanka and is the head of the Department of Medicine. He retired from the peace post in December 2017 and awarded emeritus professor. His research interests have been in strokes in Sri Lanka, epilepsy, Alzheimer's disease, and laterally the problem of neurophobia and teaching neurology. He has over 70 publications in national and international journals, including Ceylon Medical Journal, The Lancet, BMJ, Epilepsy Research, Seizures, Practical Neurology, BMC Medical Education, and JNNP. Over 80 abstracts of scientific presentations made at national and international meetings. He is a past president of Ceylon College of Physicians, the Epilepsy Association of Sri Lanka, and the Association of Sri Lankan Neurologists. He is an overseas member of the Association of British Neurologists. He was a co-editor of the Journal of Ceylon College of Physicians, chief editor of the Sri Lanka Journal of Neurology, and had been in the editorial board of Ceylon Medical Journal. He is the national delegate of the Asian and Oceanian Association of Neurology. Over to you, sir, dear sir.
All right. Yeah, you can hear me, no? Yeah. Thank you. Thank you, Dr. Jayasinghe, President, and Ranga for asking me to do this lecture today. I was very happy when you said, can you do this lecture on epilepsy? Because epilepsy is a topic which is most of the time not managed properly by neurologists also at times, and also physicians and other doctors. Because the diagnosis is difficult, because you don't see what is happening to the patient. It depends on what somebody tells you. So when a person comes, I'm not going to spend much time on diagnosis and things like that because we need to get on to treatment, which you're interested in, and the problems with management. So first thing is, I think you need to make a diagnosis. I mean, if you make the wrong diagnosis, you will give the wrong treatment, and the patient is not going to respond. So it is the most important thing, the diagnosis, getting the correct diagnosis. So we have to keep in mind the mimics or the seizures that occur in epilepsy, but they can mimic other conditions. Commonest one is syncope. And syncope, we need to remember that there can be mainly 3 types, which we need to think of. When you take a history, you need to be aware of this because the vasovagal is the commonest. Cardiac syncope is very important because sometimes they may come saying, I've had a blackout, I've had a fit. But when you check the pulse, you will find the patient is having a very slow heart rate or complete heart block. And then the other one is postural hypotension. Again, can be common in elderly people, and most are on drugs which can cause hypotension. So these must be kept in mind when somebody comes and tells you that he's had an episode. Then, of course, the real seizures or fits, as we call it, and then the pseudo seizures, but that term is not much used because sometimes the patient may not like to think that they are doing a, pseudo meaning a false thing, but they are called more like psychogenic, non-epileptic seizures. But again, even the psychogenic term is not encouraged because again, the patients may not like that word. So we tend to use a term called non-epileptic seizures or NES for the psychogenic ones. And that can be the most difficult one to diagnose and differentiate from a real fit. But these days we are lucky because the videos are there, video cameras are available in most of the phones, and most of our patients have phones with video cameras, and they tend to record these and show us. But even then, sometimes looking at it, it can be difficult to make this differentiation, but it is very important to do that. So the epilepsy, to say somebody is having epilepsy, this is what the general definition is, that is after at least 2 unprovoked seizures occurring 24 hours apart. So if 2 fits occur during, few hours, then that doesn't really amount to a diagnosis of epilepsy. But it can be, due to some provoking fact. So it has to be unprovoked. Unprovoked meaning there are no real underlying abnormality that we can identify, like meningitis, encephalitis. And 24 hours apart then we can make this diagnosis of epilepsy. And it is also important to make this diagnosis properly because you label a person with a diagnosis that runs through his life or her life. When you have repeated episodes like that, the differential diagnosis of those can be any of these: TIAs, migraine, hypoglycemia, narcolepsy, vertigo, and movement disorders. And patients or the relations may think they're having fits, but a careful history will enable you to differentiate and make the diagnosis. Yeah, then to treat properly, we need to recognize 2 things, that is the seizure types. There are 2 types that we need to recognize. And the first one is it a partial seizure? And the second one is it a generalized seizure or a primary generalized seizure? Partial seizure is, as we see in the diagram, I think all of you know that, it has a focus. We can identify a focal origin. In the primary generalized seizure, no, we can't recognize a focal origin, but it becomes immediately generalized and the patient becomes unconscious. So the primary generalized seizure, the patient, first thing that happens is he falls unconscious. In partial seizures, there can be focal onset, and it can remain confined to the focus, or it can spread to the other area. Then we call it secondarily generalization. So the treatment, the drugs used are different in these two conditions. So we come to the classification, but I don't think you need to bother too much about this, but I'm just trying to show you that there is such a thing. Yeah, so there are three main groups: partial or a focal onset, generalized onset, and unknown onset. Well, in some situations, it's very difficult to say whether it is focal or generalized. In the focal, there are two types that we need to recognize. That is where the patient is aware of what is happening. He's conscious, basically he's conscious. And the other type is where his awareness is impaired. He is not aware of his surroundings, but he's conscious still. He is not unconscious, he's not fallen down unconscious. He remains standing, his eyes are open, but he has no awareness of the situation. So one is aware, one is not aware. So the patient who is aware of his focal onset may have let's say a focal movement of the arm or the hand. So he will have a movement, repetitive movement of the hand, but he's still able to talk. He's aware of what is happening. So that's a focal onset. Partial seizure, where he's aware of what is happening. Then the second one, where he's unaware of what is happening, is mostly what you call temporal lobe epilepsies, and the previous term that we use for this is complex partial seizures, where he, let's say, in a classroom, somebody gets up and just walk up and down without any reason, and he's not aware that he's doing that. So that's can be a focal onset seizure with impaired awareness. Right? So those are the two things. And they can manifest in the following ways: motor features and non-motor features. Motor is mainly tonic-clonic movements. And also what is known as myoclonic jerks, which are again important when you come to treatment. That is muscle jerks. A tonic is you go stiff. That's normally the first thing that happens. The patient goes stiff and then starts having the clonic movements. Whereas in myoclonic epilepsies, or where myoclonic jerks are, what happens is you get a sudden jerk like that. That's all. Or arm, or both arms can go like that. If it's a more diffuse one, he can even fall with that, but he's still conscious. Right? So that's myoclonic. And also you can have other things like problems, emotional, sensory things. Then autonomic features also sometimes you can get. That is autonomic meaning excessive sweating, vomiting, nausea can be also a part of a temporal lobe seizure. Then the generalized onset seizures are divided according to the feature. That is either tonic-clonic, it can be clonic, it can be tonic, myoclonic, like that. And then the non-motor ones are the absence, what is known as absence seizures. Earlier term that is not used now is known as petit mal, was the absence seizures. Typical ones, atypical ones, and associated sometimes with others like myoclonic jerks. And also there's another type of epilepsy, it's epilepsy syndrome, where there is eyelid myoclonia, where they keep blinking eyes, but unaware of the surroundings. So in the absence seizures, the person is unaware of what is happening. Here they are, so because they are generalized onset, they are unaware or unconscious. But here he doesn't fall unconscious, but he remains unaware of what is happening. So he's absent, really. That's why it's called absence. He doesn't respond, he cannot talk. If he was doing something, he will stop that. And that is absence seizures. So that's the type of seizure classification. Then also you classify epilepsy into syndromes like this. There are epileptic syndromes which can be classified according to the age of onset: infantile onset, childhood onset, and adolescent onset. The same is generalized, and the localization related or focal ones also can be infantile onset, childhood onset. And then you get the idiopathic group and the symptomatic group. Symptomatic group means there is a cause that can be identified as the cause of epilepsy. Whereas in idiopathic, you don't know what is the cause. You can investigate, you will not find anything. Whereas in symptomatic, you will, with investigation, find a cause for the syndrome. So both these recognition in seizure type and syndromes are important, again, in the management. And out of these, I think I like to focus on two conditions just to emphasize on those two conditions, and also because it's important, common, and probably very likely for you all to see. And that is the juvenile myoclonic epilepsy, which is adolescent onset type of generalized epilepsy, and in childhood onset, benign childhood epilepsy with centrotemporal spikes. Two conditions I will just tell you because they are more common than the others, and you may see them. Yeah, so juvenile myoclonic epilepsy is a condition, it's a generalized epilepsy. Probably there's some genetic background to that, though exact mutations are not identified. It's not strongly familial, but sometimes it is possible. And what happens there is, so a young person, like age of onset is commonly about 10, 12, 13, 14 years, gets a fit. And most of the time it is early morning. Let's say school children, A-level students wake up early morning to go to school, studied last night till about 2 o'clock, and wakes up at 5 o'clock and gets ready, and then he gets a fit. Or a university student, they go on a trip. They wake up very early, go, and the night they don't sleep, they party, sleep very late, and the next day they have to go somewhere, so he wakes up early and gets a fit. So it is strongly related to sleep deprivation. That's one thing for you to know. If somebody is getting fits and it is after not sleeping properly. And another common situation is most of the times how people go for funerals, bana sermons, and spend the night without sleeping, and then the next morning they get a fit. right? So these are the situations. So that you need to be aware of. But then how do you make this diagnosis? One is that, the other one is the myoclonic jerks. The patients normally don't tell you about that. Well, they think it's part of the fate. Or I've had some minor, small things, but this happened. So they don't tell you. You need to ask them whether they get abnormal jerks. And what happens when that happens is they drop things like the early morning tea, the cup will get thrown like that. They'll drop that. That's why do they do that. Or a child who's writing, the pen will get thrown away due to the jerk like that in the mornings. Mostly the symptoms are in the morning. And in addition, they also can have absence attacks. So three things: generalized tonic-clonic seizures, myoclonic jerks, and absence attacks in these patients. And they start around 13, 14 years and then go on. And the best treatment for them is valproic acid, sodium valproate. And they respond very well. You don't need large doses. With a standard dose of 200 milligrams twice a day, you can control the fits quite well. Although you need to advise to not to break sleep, like sleep deprivation, to be avoided as much as possible. Especially repetitively, like one day if you do that, the next day sleep, or sleep late, but not to do it on consecutive nights, and very likely to get it. The drugs, sodium valproate is a drug of choice in this condition, but of course, sodium valproate, as you go on, you will realize cannot be used in certain situations like childbearing age females, or in pregnancy it is not used. In females who are likely to become pregnant, it is not used. The two drugs, best two drugs are levetiracetam and lamotrigine to use if you recognize this as the condition. If you use the wrong drug, like carbamazepine or phenytoin, they get worse. So that's other important. Right? So recognition is very important. So sometimes we tend to blanket treatment with sodium valproate, thinking this will answer, but no, some types of epilepsies don't respond well to sodium valproate also. So definitely no carbamazepine in these patients. So one way you can avoid this, if the history is very clear that it is generalized seizures, then avoid carbamazepine. But if there is an aura, onset, the neck goes to a side, mouth goes to a side, or numbness starting on some side, then it is focal. Then you can use carbamazepine. But if it's just sudden generalized epilepsy and he falls unconscious, don't use carbamazepine. And the response to treatment is excellent, but treatment is lifelong in this condition because it's a kind of a genetic situation, and so it's there. And relapse rate is very high if you stop treatment. So generally, once you diagnose this condition, treatment is lifelong. Yeah, this is a study we did a long time ago. I think it's over 20 years ago. Found that a lot of cases were delayed or missed and treated with wrong drugs. Patients were getting repeated fits. And also we found that myoclonic jerks were the most characteristic feature, but only 6 out of the 40 patients volunteered that information spontaneously. Right? So the diagnostic feature is myoclonic jerks, but patients didn't tell you spontaneously. But on questioning, most of them said they've had such jerks. So, and some were getting repeated fits due to the wrong drug being given. The other condition is this, which is seen in children. These all start around 5-6 years of age. Peak is around 6 to 8 years. And there are autonomic features like sweating, vomiting in these children. They wake up in the night sometimes, and more common when they are falling asleep. And the feature is because they are focal, the mouth, it affects the face mainly. The mouth goes to a side, the tongue starts jerky movement, so he starts drooling. He can't speak now. There's slurring of speech because the mouth is involved with a focal seizure. So he has facial twitching and head may go to one side. They can get generalized, especially during sleep. When it occurs, he can sleep through and wake up with a generalized fit. During daytime, normally they don't generalize very much. But their development, intelligence are normal. The EEG is characteristic, that's why you call it centrotemporal spikes in the EEG. The spikes, which are the abnormality seen in epilepsy, is seen in the central and temporal regions of the EEG. If it's infrequent, some people don't recommend treatment. But then the problem is we don't know when it will happen. And also the parents can be very, very stressed if you don't treat. So you need to have a discussion and start treatment. And these children respond very well to carbamazepine. And also they outgrow the condition by puberty. 14, 15 years, the condition stops. Don't continue, but may sometimes continue for a couple of years or more. But it spontaneously stops by around 14, 15 years. Yeah, so these are two conditions that you need to recognize to treat properly. Otherwise, you may give the wrong drug. So what you need to know is it a simple partial seizure, or is it a complex partial seizure, or partial seizure with awareness, partial seizure with impaired awareness. Then the generalized seizures, absences, tonic-clonic seizures, atonic seizures where he loses tone and just falls unconscious, and the myoclonic jerks, which can be generalized, but sometimes maybe both hands, the head, or the trunk. The causes, I don't think I will discuss the causes, but there are many causes. Right? Genetic causes for secondarily generalized seizures, where there's focus sometimes, genetics, abnormal brain development, cerebral anoxia, that is like birth asphyxia, or cardiac arrest following, alcohol, toxins, metabolic diseases, infections, all these can cause epilepsy. Same with like some other causes, like genetic causes, tuberous sclerosis is known, neurofibromatosis can be, Sturge-Weber is one, like that. Many other causes, tumors, strokes, infections like abscesses, toxoplasmosis, cysticercosis, TB, all can cause, and also abnormalities like arteriovenous malformations, cavernous hemangiomas are common causes of secondary epilepsy. Even for the generalized, yes. So causes we need to always think of and investigate for, but majority are idiopathic. So how do you investigate? To know the nature of the attack. Is it really a seizure? If you have problems, then we need to resort to one of these. Ambulatory EEG can be done, but not widely available. And also video telemetry can be done. You attach the EEG electrodes and video the patient. And when he gets a fit, we can record the EEG is recorded. So this is very useful in differentiating from non-epileptic seizures if it is a difficult problem. Then we need to know the type of epilepsy. That can be done by the history, and EEG changes sometimes help, not always. Then the most important thing that we have already is a patient having an underlying structural lesion, especially a surgical lesion that can be corrected, or even a medical thing like abscess that can be treated. So that we have two things that we can do, a CT and MRI. So we are looking for structural lesions. MRI is the best because even small lesions will be seen in an MRI, but the CT may be sometimes small lesions, and also certain tumors can be missed by a CT scan. So the MRI is better, but MRI is not available. Definitely the CT scan is the thing to do, and that can give a lot of information. Then of course the metabolic problems, but there of course the patient will obviously have features which you are very good at diagnosing: liver failure, renal failure, hypoglycemia. But the only thing that you may miss is serum calcium. But I'm not recommending doing serum calcium in all the patients, but somebody who keeps getting fits despite treatment may be worth doing serum calcium. And also always it's worth asking the patient if he's had any neck thyroid surgery. The patient may not tell you that. And the scar also may not be seen that well. So maybe a thing to ask. And of course, these are not necessary always, but may need to be done sometimes. Yeah, just to show you what the EEG would look like, this is a normal pattern, the alpha rhythm, and then suddenly you get this spike and wave. This is a spike and this is a wave. Right? This is a spike and a wave. A spike and a wave, and these generalized, because all the leads start at the same time. So these are generalized epilepsy or a generalized seizure. This is focal because this seems to be starting here and then spreads. So it's a secondarily generalized seizure. Yeah, again, it's the same problem. Like here, you start having changes in these both sides, and then suddenly becomes generalized. So it can be generalized spike and wave. Right? There's a spike and a small wave, spike and a wave, spike and a wave. Yeah, this EEG shows a diffuse, the whole EEG shows changes like spikes, right? Yeah. Sometimes in the very severe epilepsies, you see these changes. So what are the indications for doing brain imaging in epilepsy? Well, these very, very variable. I mean, nowadays we tend to be very liberal in doing imaging where it's available, but in your situation, sometimes where you work, these are not available, and then you need to be selective. So if the epilepsy starts like what we call adult onset, like I showed you the age onsets, infantile, childhood, and adolescent. So those are generally idiopathic. But if it starts late, after 20 years, 25 years, or especially if it's 40, 45 years, then you need to do imaging. Also, the seizures have focal features, it's good to do, though there are focal epilepsies, which are idiopathic. And the EEG shows an atypical focal source, then maybe you need to do it. Control of seizures is difficult. When it is difficult, also sometimes we tend to do this. Now, if you do a CT scan, if you're doing a CT scan, this is a CT scan, in epilepsy, then you must do a contrast CT. A plain CT is not good enough because plain CT is good for a stroke, if you're thinking of a stroke. But if it's for epilepsy, then you must do a contrast CT because some tumors like meningioma may not be seen. Now, for instance, here is a plain CT. If you look carefully, if you retrospectively, you will see that there is something abnormal here. So there are gyri and sulci here, but here you don't see them, right? So when you give contrast, it becomes very clear that this patient has a meningioma. So this can be easily missed if you didn't do a contrast CT. So if you are doing a CT for epilepsy, contrast CT. Otherwise, MRI, even without contrast will show a lesion, but to really identify what it is, you may have to sometimes give contrast. That's gadolinium. Yeah, so after a single seizure, there is a 40% risk of subsequent seizures. And also use of drugs, anti-epileptic drugs after a single seizure reduces the frequency of second seizure by half. Right. So does that mean that after a first seizure, we need to start treatment in all patients? No, the answer to that is no, only if you think the risk is high, and also having a second seizure can cause a lot of problems to the patient. Then you will do that. For instance, the patient comes with single seizure and the EEG and it's definite. There's eyewitness account, video account, very clear. It's a tonic-clonic seizure or a focal one. And the EEG also is abnormal. Then of course, I think, and he's a school child or somebody who's working in a bank or something like that, you don't want him to have a fit while at work. Or risk is high if he has a fit, then you will can start treatment. The other reason why you wait for a second seizure is when you are not sure that the first seizure is what it is, what it was. So you will wait, hoping that the second time somebody will see it and give you a better description because the patient is unable to tell you in this situation. Yeah, some key points here. I hope you can see this. One is diagnosis should be promptly made by a specialist with an interest in epilepsy. Right? So if a person like that is available, the person is a neurologist, is available, it's always good to get the first seen by him. And the decision as to whether or not an epileptic seizure has occurred should be based on both the description of the events and a review of symptoms. That we have gone through that. EEG should only be done to support the diagnosis when the clinical risk suggests it. So don't make a EEG to diagnose it because EEG can be normal. When you do a EEG in patients with epilepsy, 50% of the times the EEG is normal. The first one. So the EEG is normal doesn't mean anything. But EEG is abnormal, shows definite features, you're lucky, it's good. So that's why we don't depend on an EEG to make the diagnosis. MRI should be used to identify structural abnormalities in whom a focal onset is perceived. Seizure types and epilepsy syndromes, causes and comorbidities should be determined because incorrect classification can lead to inappropriate treatment. Initiation of appropriate treatment recommended by a specialist with an interest in epilepsy, right? So the treatment should be recommended by a specialist. Mainly, referring to general practitioners who are also treating these patients. I think they should not be starting treatment. And treatment should be individualized. Yeah, so those are the important things here. And you need to have a comprehensive plan of how you're going to manage this patient. Yeah, so how do you start treatment? Yeah, so it's monotherapy, right? Start with one first-line drug. I'll tell you what the first-line drugs are. And you start with a low dose and then gradually increase to effective control of seizures or until the patient complains of side effects of. Yeah. Now, when I say gradually increase, it's you don't double like in other situations where you double antibiotic, double a painkiller. But here you can't do that. If you double the treatment, the patient may develop immediately effects of toxicity. So what you do is you titrate the dose. Like say if you start 100 milligrams twice a day, and then you give it for 2 weeks, you know that it's not an optimal dose, but you tell the patient to come back in 2 weeks and then make it 150 in the night, still 100 in the morning. And you can advise the patient, if you're okay, after another 2 weeks, take 250 in the morning also. Right? If you think the standard effective dose is 200, then you will say, okay, another 2 weeks or 3 weeks or 1 month, you increase again from 150 to 200. So like that, it's stepwise titration rather than doubling the dose. In all the drugs, I think we do that. And then when the patient comes again, we need to, most importantly, check compliance. There are a lot of patients who don't take what we tell them to do. In my experience, I've seen so many patients. They're on 3-4 antidiabetic drugs, 3-4 drugs for hypertension, and also aspirin, clopidogrel, all that, atorvastatin, all that. When you ask them, what are you taking? They say, you know, so I ask them, then say, so you have to be, and in epilepsy, you can't do that. Right? He'll come and say, I had a fit, or he'll be brought by the people relations because he's had a fit, but they won't tell you that he's not taking the tablets. But they are frightened to tell that. But if you develop a relationship with the patient, if they are not threatened by your approach, then they will tell you. So if the first drug fails after going, let's say the standard dose is 200 3 times a day, you've gone up to that level. Now you don't think you can go beyond that, where the patient will definitely develop side effects. Then you start a second drug. Start the beginning dose of the second drug. Let's say again 200 twice a day. You give that to the patient, and after a week, you tell the patient to reduce the first drug. You don't immediately reduce because this drug needs time to work. So the second drug, you will tell, okay, after a week, you reduce. If he's taking 200 twice a day, make it, here you can be a little faster because now he's on the other drug. You say, okay, you can stop the morning one. Stop the morning 200 and continue the night 200, the first drug he was taking, for another 2 weeks and then stop. By which time the second drug you have started, you are being able to titrate it up to the dose you need. Right? So that's how you start treatment or change onto the second drug. So the recommendations are you can go up to 3 drugs like that. But if 2 drugs have failed, then it's unlikely that the third drug is also going to do much. But you can still try if you think it is possible. third drug. And then the next thing is to try a combination, but adjuvant treatment or combination with the first drug which you think is most effective, can add a second line drug. Right now, these what you have tried are first line drugs. So you can try second line drug in combination. Right? But do not use more than 2 drugs in combination at any one time because it's not going to work. Effectiveness is very low, but side effects profile is much more. Right? If it's not working, check compliance again. Every time the patient comes saying fit, check compliance. Sometimes drug levels are helpful, but we don't have the facilities to do that. Drug levels will tell you whether the patient is taking or not. Right, so these are the drugs available. After 1980s, till then it was only phenobarbital, phenytoin, carbamazepine, sodium valproate. Right, and then after 1980s, there was a rapid increase, about 15 drugs were found. Right, so we have now the first line or the first generation drugs here, and the second generation drugs are here. It's a wide selection of drugs to use now. So we don't use phenobarbital now. Phenytoin is hardly used, but it's sometimes effective, especially in the periphery when you don't have other drugs or patients can't buy expensive drugs, especially elderly people. Sometimes if it's elderly people focal normally, can be controlled, like after a stroke, after surgery, brain surgery. With phenytoin 100 twice a day or 100 3 times a day, you can manage patients. But if you have to go beyond 300, patients develop side effects. Yeah, so these are the drugs. First line drugs are these: carbamazepine, oxcarbazepine, and levetiracetam for partial seizures. Primary generalized one, sodium valproate, but you can use lamotrigine, and also levetiracetam also can be used. Absent seizures, it is ethosuximide, but sodium valproate also can be used, but this is seen in children. In adults, you don't see it usually, unless a child with absence epilepsy continues to have absence epilepsy. These absence epilepsies also stop with age, but in some it can continue. Then you will use sodium valproate. Ethosuximide is a choice for absence seizures. Myoclonic, sodium valproate, and levetiracetam. So like I told you, in the juvenile myoclonic epilepsy, sodium valproate cannot be used in females of childbearing age. Then you will use levetiracetam. Right, so the drugs, what are the drugs we have? What are the drugs I use commonly? Carbamazepine, oxcarbazepine, levetiracetam, sodium valproate, not much lamotrigine, topiramate, yes, when it's mostly focal, as a second add-on drug. Like if it's not, responding well to one of these, still getting fits, then you will add topiramate to this, but not as monotherapy. But there are studies and recommendations that topiramate can be used as a monotherapy, but topiramate has a lot of very bad side effect profile. Yeah, I don't think we need to look at this much, but these are just to tell you what are first generation drugs: valproic acid, carbamazepine, phenytoin. Second generation are these: lamotrigine, levetiracetam, topiramate, zonisamide is not really available, and oxcarbazepine. Right. So what are the important adverse effects to know? Carbamazepine is very, very well known to cause adverse effects, but that is if you don't start treatment properly. So all these drugs have side effects and are common to all medications, and when prescribed at too great a dose and are similar to being drunk. Right? That's what happens. So sometimes you see patients on carbamazepine, dose had been doubled, and another one had been given, added, and he comes to you. He's very ataxic. He says he can't see properly, blurred vision, and his speech is also a bit slurred. So if you're not aware of the situation, you will do a lot of investigation. You will do a CT scan, MRI scan, thinking he's had some other problem, whether he has a tumor, whether he has a stroke. But his problem is this, right? So all you have to do is reduce the tablet, right? So confusion, ataxia, a rash, rare, but can be very severe. So you have to warn the patients. When you start on carbamazepine, if you get a rash, please stop the drug and come, right? If the dose is high, blurring of vision. Then also blood dyscrasias are described, but we hardly see them. Sodium valproate, vomiting, hair loss. But hair loss is not a problem because they initially lose hair, but it comes back. Liver toxicity is an idiosyncratic effect, very rare. Pancreatitis, very rare. Weight gain, people sometimes complain. Increased appetite and weight gain go together. And tremor. If you give high dose, some patients develop tremor. So those are the common problems. Now, topiramate, if you're starting, my advice is don't really start topiramate. Difficult drug, but it has cognitive slowing, mainly cognitive problems, decreased attention, and also they have these, it's rare though, word finding difficult. The speech, they find sometimes the words they want to say don't come. Right? So that's cognitive. Kidney stones occur in about 1%. So you need to advise them to drink a lot of water. And they, unlike in sodium valproate, these people develop decreased appetite and weight loss. So therefore, this topiramate is even used as a weight-losing drug. Then they may complain of paresthesia in the hands and feet, but this is a temporary effect because this drug has a carbonic anhydrase inhibition activity. And they develop a bit of acidosis and they develop paresthesia in the hands and feet, but it settles after a time. And oligohydrosis, absence of sweating, and then because their temperature might go up, especially in hot conditions. Then another important thing is to remember is if the patient complains of headache and pain around the eye, this drug can induce glaucoma. So you need to immediately stop the drug and refer for IUP. Yeah, so these are the important drugs, and also it has an increased rate of birth defects. Yeah, so but it is approved for initial monotherapy, focal seizures, and generalized tonic-clonic seizures, but it is not the drug of first choice. But in an obese patient who wants to lose weight, who has migraine, where there is a treatment of migraine as well, but even in high doses, then this drug may be considered as useful. And these have to be started with a small dose, like 25 milligrams daily, then gradually increased, and you can go up to 100, 200 milligrams, but very slowly. Yeah, levetiracetam is a safe drug. There's no drug interactions with that, safe, and also it's useful in pregnancy, no teratogenic effects. Widely used as a first-line treatment, and is approved for initial monotherapy in Europe, but FDA approval I don't think they have got it yet. So what happens? Outcome after 20 years without drugs, patients, about half of them will be seizure free for 5 years. That is, after you stop treatment, 50% will remain seizure free for the next 5 years. 20% will be seizure free, but with medication. Other 30% will continue to have seizures despite treatment. Right? So 50% do very well, 20% have to be on treatment continuously, but they are controlled, and the 30% poor control, or what we call refractory epilepsy. So when do we withdraw the drugs? The patient is on examination normal, no focal signs like brain injuries or tumors operated or strokes, normal IQ, which is an indication that he has no underlying disorder, and a normal EEG, though it is not always necessary, normal EEG is good to have, and no fits for 2 to 5 years or long. And also, you have to make sure that there is not juvenile myoclonic epilepsy. Then you can start withdrawing the drug, but that is also again done very slowly. If the patient was on, let's say, 200 milligrams or twice a day of carbamazepine, then you will reduce to 100 in the morning, 200 in the night for a month. After a month, 100 twice a day for another month, then stop the morning 100, and after another month, stop the night one. So it may take about 3 years, sometimes even 3 months to 6 months to stop treatment slowly. If you rush, sometimes you may precipitate seizures. The oxcarbazepine, which is also commonly used now, which is commonly available, is a better drug in the sense less side effects, less rash, and so easy to use. But the dose-wise, it's 150 of oxcarbazepine is equal to 200 of 200 of carbazepine is equal to 300 of oxcarbazepine. Right? But it is said that another side effect of carbazepine is hyponatremia, especially people on thiazides and all that. You may have to be aware of this. It is said that it is more with oxcarbazepine. Otherwise, oxcarbazepine is a better drug to use, easy to use than carbamazepine, but effectiveness similar. Yeah, so the last few slides, let's quickly finish this. Drug-resistant epilepsy, of course, is after failure of 2 appropriately chosen and tolerated drugs. And if the patient continues to have seizures, then you can call it drug-resistant epilepsy. But it should be the appropriate drug. If you have used the wrong drug, then no, it doesn't apply. And the treatment has to be adequate. Doses has to be given. Right? So that's important. Yeah, so the first trial with monotherapy, second trial, then third monotherapy or polytherapy trial with a combination. And then, of course, you will think of epilepsy surgery if they are focal. If they are generalized idiopathic, then there's really no place for surgery. And surgery-wise, you can remove the focal lesion if you can identify. If not, you can use vagal nerve stimulation. Is another form of treatment that can be done, like a pacemaker. You fit something, it stimulates the vagal nerve, which inhibits seizures, and also continue with polytherapy, AED trials. And in certain types of epilepsy, especially in children, you can go for a ketogenic diet, which is full of fats, low in carbohydrate. Yeah. Right. So these, I think we have done this. But yeah, few words on pregnancy. Seizures can be very harmful for a pregnant woman. And also in pregnancy, once you become pregnant, a patient who's on drugs, their drug levels go down. Because renal clearance is more when you're pregnant. The drug is cleared faster, so your drug levels go down. So that might make the epilepsy worse. So you may have to increase sometimes the dose. Monotherapy, folic acid is recommended when treating. Phenytoin, sodium valproate are absolutely contraindicated. And oxcarbazepine is better than carbazepine. Experience with the new ones are still not reliable to say that they are better than the old ones. But if you look at this table, first lamotrigine and levetiracetam are the most widely used due to their known safety. Right? Lamotrigine, levetiracetam. But if a patient is already, let's say, on sodium valproate, and you can't stop it immediately, if it's a low dose, then you can continue, because there's recent evidence that if the dose is only about 800 or 600 or 800, that the effect is significant. So if that is the only drug that the patient is responding, you can continue 400 milligrams or 600, but if it's more than that, then that can cause problems. Yeah, so these are the birth abnormalities. General population is 2 to 3 of 100 babies. Carbazepine 4 to 5, phenobarbital 6 to 7, phenytoin 6, topiramate 4 to 5, and valproate is 10%. 10% malformations with valproate, and also 30 to 40% of children on valproate will have problems with cognitive development, neurodevelopmental problems later in life. Right? So therefore, valproate is not recommended, strongly not recommended, unless that's the only drug the person is responding. Yeah, so lastly, I think, yeah, how do you recognize pseudo seizures or psychogenic non-epileptic seizures? Can be difficult. Even after seeing, it's difficult. Yeah. If the patient's consciousness is waxing and waning, like becomes conscious, becomes unconscious, then comes up, then it is possible that that's not epileptic. Then out of phase shaking movements. Not all limbs are moving synchronously. One limb the other way, one limb the other way, kind of legs in a different way. Unlikely epileptic, but frontal lobe seizures sometimes can be like that. Right? So then pelvic thrusting is another feature of pseudo seizures. Side to side head is pseudo seizures. Right? Normally the head goes like that, the mouth opens. Mouth opens and the head goes like that. But if the head is shaking like that, then it is more like pseudo seizures. Eye closure is also a pseudo seizure. Eyes open in a normal fit. Here where the eyes are closed, and also if you try to open, they resist opening, it's more likely a pseudo seizure. Clenched mouth during the tonic phase. normally the mouth is open during the tonic phase, which is the initial phase, the mouth opens. And when the clonic phase comes only, it starts clenching and you bite your tongue. Post-ictal confusion and somnolence or sleep after the seizure or the ictal event is absent in pseudoseizures. And also they might show a startle response. If you make a loud noise, they might jump up. Whereas a real seizure, nothing will happen, right? Yeah, so those are some features that will help, but can be still very difficult. Yeah, the last slide is about driving. Well, we don't seem to have really clear regulation, but I think it's 3 years or something. If you have epilepsy, you have to be fit-free for 3 years. But the general guidelines are UK ones are 1 year, free of recurrence. And you have to inform the DVLA and surrender your license. And if you still drive and you are found, you can be, I think, penalized for £1,000 or something. Right? So 1 year. But if your seizures are confined to sleep for a period of 3 years, then you can drive. No daytime fits, but for 3 years on, it's only during the night. Right? And when you're withdrawing also, you have to stop driving for 6 months. Right. Yeah, heavy goods drivers, public service buses and things like that, trains, 10 years, seizure free. Yeah. So that's, I think, all I have. Yeah. So thank you very much for listening.
Thank you very much, sir, for that very illustrative and excellent lecture. I think we have several questions, sir. Is that all right if I take up the questions one by one?
Yeah, sure.
The first one is, is the term partial seizure with secondary generalization now replaced by the term of partial seizure with impaired awareness?
Yeah. Sorry, you are asking me? No, not really, because impaired awareness is different. But the secondary generalized is another category. Yeah, we have partial onset with awareness, partial onset with impaired awareness. That is a temporal lobe. But when you say partial seizure is secondary generalization, that goes on to a tonic-clonic seizure, whereas impaired awareness may not go into a tonic-clonic seizure. He will behave abnormally. He will just mutter something, and he will start unbuttoning or doing something which is unaware. But here, the partial onset, and then goes on. It spreads. You can go like that. You go like that, and then starts shaking like that. So that's secondary generalization. Whereas idiopathic onset generalization is suddenly no such thing. Suddenly you start just go like that. So it's not the same thing.
The second question is, can hypokalemia, metabolic acidosis cause seizures in children?
Metabolic acidosis, yes, but hypokalemia, no, because hypokalemia causes paralysis. Anyway, I'm not a pediatrician also, but acidosis, yes, metabolic acidosis, but hypokalemia is generally not considered as cause for seizures. But only thing is the hypokalemia may be associated with the cause of hypokalemia. Like renal tubular acidosis, you get severe acidosis with hypokalemia, like that. So it can cause, but the hypokalemia itself causes muscle paralysis rather than seizures.
This third question, sir. In a provoked seizure, if we start patient on anti-epileptic drugs, and if the provoking factor is treated, when do we stop anti-epileptic drugs, and do we do the NEEG before stopping?
Yeah, so depends on what is provoking. Let's say patient has encephalitis, had encephalitis, had 2 seizures. right? And then you treat. So there are, of course, there are no strict regulation, but up to 6 months to 1 year, you treat. Yeah, but if there are structural abnormalities due to the encephalitis, the patient had, let's say, changes like scarring, or sometimes because the encephalitis can cause hemorrhage, necrotizing encephalitis, things like that. If there were abnormalities in the MRI, then maybe longer. EEG may not be very useful in this situation because these are not idiopathic epilepsies. EEG may not show anything later on, maybe normally. So you go by the normal imaging and the duration, know if it's for 6 months or 1 year, then you can start telling. But if it's a tumor, which has been removed, tumor of the provoking factor removed, but then the scar is there. And also you may consider giving it for a longer period. And if the patient wishes, you can, and what I didn't tell you is that when you're doing that, when you're stopping, you have to discuss with the patient. If the patient is not willing to stop, best is not to do that. You can explain to the patient and no side effects. He's very happy with the tablet and there is a small risk, you will continue. But if the patient says, no, I just don't want to take this, then you may explain to the patient again and go on a quicker withdrawal. But there are no rules really. Yeah.
Thank you, sir. And this is from Prof Shamila Metanand. I think what is the reason for a previously healthy man to all of a sudden to develop a partial seizure in his 70s?
Yeah. Well, in 70s, yeah. So now the thing is, when you're saying he's perfectly healthy, but it's still the brain is aging. So there are sometimes the changes in the brain. Now, for instance, if you have Alzheimer's, they develop fits. But if you're talking about a normal brain, really, I don't think I can answer that question to you because, I mean, there's no reason why you should get it. But maybe, I mean, if he's drinking, I mean, if he's drinking, then are you still in the UK or here? But because in UK, these old people drink so much that maybe he's drinking and he has got an alcohol-induced seizure. But I don't think we can say why, but except for the changes that occur with aging, is also known there are brain changes, especially if there are changes like amyloid deposition, maybe asymptomatic, and you can get the amyloid spells, or amyloid spells which are not fits but look like fits, like that. So if it is after doing all this, then of course you have to label it as idiopathic focal, but I don't think in classifications there is any category like that. Elderly onset idiopathic focal epilepsy.
The next question is, I think Sir has asked, given an answer for this question as well.
Yeah.
Mention the advices and regulations related to driving and epilepsy.
Yeah. Sorry? Is that a question or?
Yeah, it was a question, but you have answered this question during the lecture, isn't it?
Yeah.
So if a patient is on valproate, seizure control well for 1 year, found to be pregnant, what do we do, sir? I think that also you have answered, isn't it, sir?
Yeah, one thing is the patients who are on valproate who are likely to be pregnant, you have to warn beforehand, don't get pregnant. Right? Don't get pregnant. If you decide to become pregnant, then discuss beforehand so that you can either reduce the dose if it's a higher dose or try to change over about 6 months into something like levetiracetam, which can probably control the seizures. But if the patient without telling becomes pregnant, then it's an issue. You have to tell the patient you can't do anything now. You will try to bring it down. If the epilepsy you think is very bad, you have no choice really, you have to continue. But epilepsy is well controlled, then you can still try and change to drug like levetiracetam or lamotrigine, which are safe in pregnancy, and try to reduce the valproate as quickly as possible.
That's an interesting question.
I have seen a lot of patients who continue on sodium valproate, but on a low dose, 200 twice a day or something, they hardly get any malformations. But then what is known is it's only with higher doses that this happens. But recommendation is then not to use sodium valproate. And also if they become pregnant, you should have a plan whether to continue with the pregnancy or not. Even that's what the UK recommendations are. If patient is on high doses.
Dr. Keminda Tilakaratne, you have raised your hand. If you want to ask a question, you can go ahead now. Dr. Keminda Tilakaratne?
Yeah, actually, it was a mistake. I thought it was a mistake. Sorry about that.
All right. Okay. Thank you. The next question is really interesting question. So, if someone misdiagnosed for a condition which is not a seizure and treated with anti-epileptics, will it cause any serious effects on the patient?
Not really, but all these drugs have side effects, like I showed you. But no, if it's it's like treating a person, or if you treat a person with epilepsy with, let's say, sodium valproate, counspheno, levetiracetam, or the same thing, like it's not going to change. But then that person is taking something unnecessarily. If he's spending money on that, and also depending on the drug and the dose. If you give one tablet daily, nothing will happen, really. But if you check, sometimes these drugs induce liver enzymes, and if you're on other drugs, then you have to be careful because they can lower the effect of anticoagulants, contraceptives, and even other drugs, which are like antibiotics sometimes, lower the effect because some of these like carbamazepine, phenytoin, phenobarbital, they induce liver enzymes. And so they increase the metabolism of other drugs. Otherwise, I don't think there'll be much of effect if you give a small dose. Patient may not recognize. Till you realize your mistake and change, I think it's okay.
I think we have answered all the questions, and thank you very much for your time and dedication to enlighten us regarding these very interesting topics. And I thank you again for swiftly accepting our request on behalf of the President and the Council of Sri Lanka College of Internal Medicine for this brilliant lecture, sir.
Thank you very much, Ranga, for asking me to do this, and thank you for all of you, and thank you, Kumudini, also, for giving me this chance to speak on a topic that I kind of like to speak. And if it has helped you all in any way, I'll be very happy. Thank you. And
thank you very much, sir. Good night, sir. Thank you. Thank you.